So the first part of it, this is multiple trauma, abdominal trauma. So the interventions are going to be frequent vital signs. If you're in the emergency department and they're just coming in, we do Q5s because that's how quickly things can change. If they're stabilizing out, we can move to Q15s. If the stabilizes out, we can move to Q1s. And then from Q1s to Q2s, Q2s to Q4s, the Q4s to Q8s or whatever. But you do them as frequently as needed until the patient starts to stabilize out. And that's going to be probably based upon the receiving of fluids because it's fluid volume deficit. So vital signs should be done as often as needed. But we're not going to start with Q-shift vital signs. We're going to start with very frequent vital signs, looking for the first vital sign change, which is tachycardia, a heart rate greater than 100, followed by hypotension, which is a blood pressure less than 100. Now that is for an adult. It is different for the pediatric patient. You all know peds patients have higher heart rates and lower blood pressures. But I'm talking about adults right now, okay? We're going to do their INO Q1 hour until they are stabilized out. Remember that urine output is a reflection of your circulating blood volume. It is not really reflection of your renal function, unless you have a reason like renal disease that, or either you're on a nephrotoxic drug or something like that. But for a trauma patient, it's not their kidneys that are bad. It is their circulating blood volume. And how do we know what their circulating blood volume is? One of the indicators is the amount of urine output that they're putting out. So we need to do their INO Q1 hour and see, did they put out at least 30? We would like to see 60, which we consider normal, which would indicate our circulating blood volume. Assess their pedal pulses every hour. Again, with a palpable pedal pulse, you will have a systolic blood pressure of at least 100. Doing frequent neuro checks, doing frequent Glasgow Coma scores. Are they decreasing? Are they increasing? Are they better? Are they worse? We know that people can go to sleep, and so they're allowed to drop a little bit. 13, 14s, and 15s are considered normal. It's usually based upon falling asleep and that kind of thing, getting pain medicine and that type of thing. So we don't worry too much at 13, 14, and 15. Under 13 is a little bit concerning. Under 8 is typically a coma. So we sort of need to watch their Glasgow Coma score. Checking their cap refill. Cap refill is perfusion. It is circulating volume. It is treated with fluids. It is not treated with oxygen. It is treated with fluids. It is end organ perfusion. Watching their hematocrit and hemoglobin levels. You've got to have, that's what they're most at risk for, is hemorrhagic shock, loss of blood. So we got to watch, is their crit dropping less than 30? Is their hemoglobin dropping less than 8? Typically we transfuse when the hemoglobin is less than 8 and the hematocrit is less than 30. So we got to watch what's the trend going on here. Doing CVP readings about every one hour. CVP is a indication of fluid volume. That's what we look for, is fluid volume. When Jane talks about hemodynamic monitoring, she'll talk about the difference between a CVP, which is fluid volume, and a Swan-Ganz, which is left ventricular function, left side of the heart function. But CVP is for fluid volume. When the CVP is high, they got too much fluid. When the CVP is normal, they got adequate circulating volume. When the CVP is low, they don't have enough circulating blood volume. That is blood volume, okay?
What's the normal CVP reading?
Well, different people will give you different. Most people say 3 to 10 type thing. 3 is a little low, but 3 to 10. What was on the previous page?
Oh, 5, yeah.
5 to 10. 5 to 10.
Okay.
3 is a little low, but we probably would accept 3 to 10. We would look around 3 to 10, but it's depending on what it was before. If they were sitting at 8 and they dropped to 3, we would be concerned. But if they were sitting at 5-ish and they dropped to 3, we'd we would just kind of be watching them, sort of thing. It's what's their trend, but 5 to 10. And a lot of it depends on where you work, what they use as a standard. When I was in the ICUs, we used 3 to 10, but I think your book says 5 to 10. Okay. Looking for any evidence of bleeding. So checking those dressings, putting your hands underneath your patient if they don't turn real well, and pulling away. Blood goes downhill by gravity. So you may look at their wound on the top and say, oh, look, there's no shadowing, there's no bleeding there. But when you put your hand under them, you come away and your hands are bloody. Often you get blood pooling behind your patient. So you always want to check on that. You may have a wound on an arm and say it looks good, but when you pick it up, they've got a big old pocket of hematoma sitting under their arm here. So it may not just be external hemorrhage, it could be internal, like in a pocket of interstitial space that you see a big hematoma. So is there any evidence of them still bleeding? It's somewhere. And then we're going to do the 3-to-1 rule for IV fluids and 1-to-1 rule for blood products. Sometimes it's an estimate because sometimes we don't know how much blood they lost, but we may have to estimate what we think it is. And sometimes we're actually able to measure it. But that is how fluid replacement is done. Now, for abdominal trauma, there's a very specific test that can be done. Now, yes, we can do an ultrasound and they can see blood. And at a level 1 trauma center like Carolinas Medical Center, we have those ultrasounds. On Grey's Anatomy, they have that ultrasound, but not everybody has it. And so one of the tests, and I do know that this is on NCLEX because I've seen questions about it on NCLEX when I've read for students before. So one of the things is we will do what's called a peritoneal lavage. Now, a peritoneal lavage, people will call it peritoneal lavage. People will call it a diagnostic peritoneal lavage. They will abbreviate it and call it a DPL, meaning diagnostic peritoneal lavage. Or they'll get a little lingo in there and call it a belly tap. Okay, they'll say, we're going to do a belly tap. All right. Now, what they're going to do is they're going to go in and see if there's any blood in the abdominal cavity, in the peritoneal cavity. Okay. Now, as a nurse, before they do this, you have some major responsibilities, and that is to make sure that the stomach is decompressed and make sure that the bladder is decompressed. The way you decompress the stomach, does anybody know?
OG tube.
Put an OG tube down. Very good. And remember that we use the term OG and NG interchangeably. All right, but we're going to put it down their mouth. You're exactly right. We're going to decompress the stomach with an OG tube. All right. And then how do you decompress the bladder?
Some sort of catheter.
Like what? What do we call that catheter?
An in and out or a Foley.
Right, we'd put a Foley in them. We'd put a Foley in them because we also need to do urine outputs every hour. So they're going to need a Foley, okay? As long as there wasn't a blood at the meatus on a man. In that case, they'd insert a suprapubic on him. But typically 9,999 times out of 100, it would, or out of a whatever, high percentage would be a Foley, would be put in the patient, okay? And so we're going to decompress the stomach and decompress the bladder. So as a nurse, if they said, okay, we're going to do a belly tap, and you said, wait a minute, I got to get an NG in them and I got to get a Foley in them before you can do that. That's a major nursing responsibility. Okay, so then they're going to go halfway in between the umbilicus or the umbilicus, whichever way you want to pronounce it is correct, and the symphysis pubis. They're going to go halfway in between. Put the finger in their belly button and go down. Put their finger on the symphysis pubis and come up, and that's halfway in between. And they're going to make a little numb, put a little lidocaine in there, lumb it up just a little bit, just a little tiny wheel, little tiny spot. And they're going to make just a little tiny incision, maybe 1/8 of an inch. I mean, it's little tiny. They don't even put a stitch in afterwards usually. It's little tiny, okay? Then they'll take what's called a Tinkoff catheter. And it's the same catheter that's used for peritoneal dialysis, right? And it looks like an IV catheter that's bent. And so they'll slide that into the peritoneal cavity and it just sits there, okay? That's all it does, it just sits there. So once they slide it in there, the first thing they do is stick a 10 cc syringe on it. Now at CMC and Atrium Health, our 10 cc syringes are 12 cc syringes, just to let you know, they don't have 10 cc syringes. But a 10 cc-ish syringe, they screw it on and they aspirate back on the syringe. If they aspirate back and the whole syringe comes back blood, that is considered a positive diagnostic peritoneal lavage, meaning, yes, there is bleeding in the peritoneal cavity. That patient needs surgery. That patient is got internal hemorrhage. Take them to the operating room. And so the Tinkoff would be pulled out, slap a dressing on top of it, fill out the OR papers, off they go to the operating room. But if you aspirate back and you only get 1, 2, 3, 4, less than 10, lots of little bubbles, just a 1 cc with some bubbles, but not a full syringe of blood, then there's not a lot of bleeding. They're not that. So if that happens, the next thing you do is you take a bag of warmed normal saline, IV fluid normal saline, put it to regular IV tubing, just a primary set of IV tubing. Don't put it on the pump, just prime the tubing. Take the end of the tubing and put it into the Tinkoff. Open the tubing up and let that liter of saline go right into the patient's abdomen. After it's in, take the tubing off the IV pole and drop it to the floor. And now that bag becomes your drainage bag. And now the fluid runs back out like a Foley bag would be. Okay? So you ran in, that's the lavage part. You run in a liter and you let that liter run out. Now you probably won't get the whole liter out. You'll probably get about 800 out. Okay. After that's done, you clamp it off, take your IV bag, and you look at that fluid. And we do what's called, excuse me, the newspaper test. It's just what it's called. You don't have to have a piece of newspaper, right? You look at that bag and you say, give me a piece of paper that has writing on it. So this piece of paper has writing on it. See, it has writing on it. Put that paper down, put the IV bag over it. Can I see through that IV bag and read that paper on the other side? In other words, it's clear enough that I can see the letters through that IV bag. If it's too red, if it's too pink, if it's too brown because there's poop in it, or too any other color, that it's too opaque, it's too cloudy, that I cannot see through to the other side, I don't have to read, today is January 14th. I mean, I just can't see the letters on the other side. Then take the Tinkoff off, slap a bandage on it. They're going to the operating room. So if I'm unable to see through that drainage of that IV bag, they're going to the operating room. But you know what? Even though it's really pink, it is a clear pink. I can see through it. So they might have some blood in there, but it doesn't look like it's continuing to bleed. It looks like there was some, but it wasn't a whole lot. So there's a third thing we do. We take that IV bag and we put an addressograph label on it that identifies the patient. just like we were sending labs upstairs. And the lab gets that. And the lab, there's established lab values. It looks at how much glucose is in it. It looks at how much protein is in it. It looks at what's called vegetative matter. Vegetative matter would be like corn, green beans, like that would mean like your stomach is ruptured. It looks for a certain amount of white cells of bacteria. White cells would be indicative of your spleen being ruptured, and it got that in it. It looks for poop, like fecal matter in it. That would mean like your bowel ruptured and there was poop in it. So there's all these things that they're looking for. Amylase, lipase, that would mean that your pancreas was damaged and it's in the cavity. So if those come back higher than what's accepted, then that could indicate something was ruptured, and that would send them to the operating room. If that comes back normal, then okay, their belly's clear, their belly's good. Okay, so the peritoneal lavage is a diagnostic procedure for blunt trauma that helps us to see if this is somebody that needs to go to the operating room. Typically for places that don't have abdominal ultrasounds at the bedside and don't have, well, mostly abdominal ultrasounds at the bedside. We still do some in the ER. Not as many as we used to. We used to do them on almost everybody, but not as much as we used to. Okay. Another nursing diagnosis, or the last one, is pain. We diagnose it also by pain. And it's done with serial exams, continuing exams, because it is irritation to the lining of the abdominal cavity. And so it is important that they do not receive pain medicine of any kind, listen, until a diagnosis is made. Once a diagnosis is made, they can have pain medicine. All right, you come in with a knife stuck in your belly. I have a diagnosis. You can have pain medicine. You're going to the operating room. Give them something for pain. You're shot. You're fine. You know, if you have an ultrasound and we see free air or free blood in your abdomen and you're going to the operating room, we can give you something for pain. You've got a diagnosis. But I don't see free air. Free air usually means your bowel is ruptured or your stomach is ruptured, typically. Free air usually means bowel. I don't see free air, and I don't see any blood really in there. But you really have a lot of pain. Let's watch that pain and see if that pain's getting better or is that pain getting worse. Is it only muscular pain or tissue pain, or do you have something ruptured that I can't see? Well, if I mask your pain, maybe it's something that's not ruptured, I'll miss it. And then you're going to have peritonitis, which is life-threatening. Right now, it may not be life-threatening. So they're not going to give you anything for pain until they make a diagnosis. We can help you, though. We can try to treat you symptomatically. As long as their spine is clear, typically, if you're laying flat, your pain will be worse than if we sit you up so that you're not stretched out. If you can bend your knees, that will help your pain. To bend your knees up will help some. An NG tube and a Foley will often help abdominal pain, just decompressing your Foley and your stomach so it's not pushing on so much taut in there. You can have that, but you cannot have anything at all for pain. I've had people say to me, and this isn't trauma, but I've had people say to me, you know, I hate your ER. I said, well, that's your right. You know, we went over there and we went over thinking we had appendicitis, and we sat there for like 8 hours and they never gave me anything for pain. Can you believe that? And I said, did you have appendicitis? No. I said, then you got the best possible care, because that is how they diagnose your appendicitis. What did your pain do? If you did have appendicitis and they gave you something for pain and it ruptured, now you have peritonitis and now you're in a life-threatening, you're sick, you're PICC line, 6 weeks of antibiotics at home. You don't mask the pain. Now, if they done an ultrasound and saw a hot appendix and you were going to the operating room, then you give them something for pain because you know it's a hot appendix and you're going to the operating room. But they did not see a hot appendix. Therefore, they're going to watch you and see what your pain does. Pain is a determining factor of diagnosis in the abdomen. You do not treat abdominal pain. You watch abdominal pain, don't treat it. But once you know what it is, you can treat it. But not until then. That's real important. You don't treat abdominal pain. And abdominal pain hurts, please understand, but you don't treat it. All right. Another kind of trauma is obstetrical trauma. About 7% of pregnant women will be injured during their pregnancy. Motor vehicle accidents, it will be the #1 cause of death of the mother during childbearing ages. It is not delivery. It is not a childbearing issue that kills women during the childbearing years. It is motor vehicle accidents. The second most common is falls. It is not delivery. It is trauma that kills women during their childbearing ages. All different kinds. Head is the most common. Pelvic, because of the dilation of their pelvic vessels, they're very, very prone to hemorrhage. They can get diaphragmatic tears, especially in their 3rd trimester, where they got that big old grab at a uterus. It can pop their diaphragm, and diaphragmatic injuries are very, very, very serious. Bladder injuries, where the bladder pops. Uterine injuries itself, where the uterus has a tear in it. And then you don't typically hurt the fetus until the 3rd trimester. The symphysis pubis protects the fetus very, very, very well. But in the 3rd trimester, when the uterus is really out there, you might also injure the fetus. But usually in the 1st and 2nd trimesters, you do not usually have fetal injury during the 1st and 2nd trimesters. Usually it's not until the 3rd trimester that you get fetal injury. The nursing care of the pregnant patient is the exact same as the non-pregnant patient. You do not think about the baby or the mother in any different terms until you get to H. Once you get to history and head to toe assessment, that is the first time you consider the pregnancy-related condition. Now, if she has gushing blood running down her legs, that is a bleeding problem, and that would be a C. But if she has a foot hanging out of her vagina, that is a nothing. That is an H. When you go through the A, B, C, D, E, F, G, H. Okay? You do not treat this mother any different than you do the non-pregnant patient. The OB part comes in under H. And that's where you're going to find out, is she having contractions? You look between her legs. What's between her legs? Do you see anything? What does the drainage look like? Is there body parts coming out? If there is, remember, you don't go forward until you do something about it. Oh, yeah, there's a head. Oh, let's deliver it. You know, this is where you ask, when's the baby due? Have you had any complications? You know, looking for uterine contractions, that type of thing. Unless there was hemorrhage present, and that would fall under C. All right. So this would be, you might need to think about positioning. Remember, we typically turn the mother due to supine hypotension. If you know they're in their 3rd trimester, you might need to position them. That is also probably going to be a treatment under C. If you have a big old gravida uterus, then and they're hypotensive, they're going to be getting fluids, but you also may, let me put this person in, you may also consider turning them up on their left side, which might help their blood pressure. But you learned that in OB. What do you do for a hypotensive mother? You turn them up on their left side to get them off their vena cava, to increase their blood return back to their heart. They're compressing their vena cava, bringing forth things from your 154 course. Okay, so OB doesn't come into play until the H in the systematic trauma assessment. We do nothing else different in this patient. Nothing. Okay. Now, so if they're just like anybody else and we get them through the trauma part, what happens as far as OB? What type of OB situations do we classically see in the obstetrical trauma patient that we don't see? Let me rephrase that. What are the obstetrical complications that we do see in the patient that is pregnant? What do we typically see? If they're going to have complications, what are the complications that we see? The most common complication is it will cause preterm labor. So when a trauma patient comes in, we will deal with their A, B, C, Ds, EFs. We were going to deal with all those first, all of that first. Once we get them stabilized, then we go to the OB part. Whether it is a twisted ankle or whether it is a major head-on car crash, we're going to deal with the A, B, C, D, E, F, G first. Okay, so if you came in and let's just say your ankle's twisted. Okay, you fell, or you didn't necessarily fall, but you twisted your ankle and you kind of stumbled and you didn't fall and hit your belly or anything. You just twisted your ankle and you're more than 20 weeks pregnant. And by the way, we use 20 weeks. This isn't just to let you know why 20 weeks. Why wouldn't you do this when you're 16 weeks pregnant? Your fetus is not viable before 20 weeks. So we're not going to do anything before 20 weeks. And if you want to know why the fetus isn't viable before 20 weeks, I don't know if they cover this in OB or not. When your trachea forms in utero, your trachea forms from the top down and from the bottom up, and the two do not fuse until 20 weeks. So if you deliver, let's say you deliver an 18-week fetus, and it's moving, its eyes won't be open, but it's moving and it's trying to make breathing effort. Believe me, I've delivered plenty 20-week fetuses in the ED. And they'll say, well, maybe it's 20 weeks, maybe. And the doc will try to intubate it and they'll try to put a little tiny ET tube down and it'll hit just a dry pocket right here. It will not go down. It can't, there's nowhere for it to go. It has to be at least 20 weeks for the two to connect and to be able to ventilate the lungs. So we use if you wonder where this arbitrary 20 weeks came from, it's really not as arbitrary as you think it is. That's why we don't do anything earlier than 20 weeks, because the fetus is not viable earlier than 20 weeks. Okay, so if you're over 20 weeks, then you will go upstairs to the labor and delivery and they will monitor you for signs of preterm labor. So we're looking for contractions. We're looking for, any signs that your abdomen is tightening in a rhythmic type of pattern. Any signs of premature rupture of membranes, like, fluid or any bleeding or they may take a quick look with a sterile speculum and see if your cervix is dilated at all. So they're going to look for any signs of preterm labor because it is the #1 complication of trauma. It can send you into preterm labor, and it doesn't have to be bad trauma. It can be any kind of trauma. All right, so they would look for that. Another thing, not as common, because it's not the #1 thing, but it is a thing that usually results from trauma, is an abruptio placenta. Now, an abruptio placenta is the pulling away from the abdominal wall of the placenta. It results in significant vaginal bleeding and hemorrhage. You will have a huge amount of bleeding, vaginal bleeding. It is a premature labor situation, but it is with large amounts of bleeding and cramping. Abruptio placenta is described as painful vaginal bleeding, cramping vaginal bleeding. Just to let you, this has nothing to do with trauma. To differentiate between placenta previa, which is the growing of the placenta across the cervical opening, is painless vaginal bleeding. Abruptio placenta is painful vaginal bleeding. There's the two differentiations between those. They both bleed like stink, just let me tell you. They both bleed a lot. But placenta previa is painless. Abruptio placenta is painful. That's how you differentiate those. Okay. This baby is not getting any oxygenation because they're not connected to the mother anymore. So you have severe fetal distress, whether it's hyperactivity or hypoactivity or tachycardia, fetal tachycardia or fetal bradycardia, either one. And the mother is hemorrhaging. So you're going to see tachycardia in the mother with hypotension in the mother. All the signs we've already talked about of hemorrhage. And if the head of the baby is already engaged, they could be like a plug of the vagina, in which case you're going to see the abdomen getting bigger and bigger and bigger because the blood is like stuck in there. And I have seen that. And what do? You get out your measure, you get out your tape measure, and you mark your lines. You go, and you come back in a few minutes later and you measure it again. You go, ooh. And your butt pucker goes, whoop. And your eyeballs go, whoop. And you go, this is not good. Get me a doc in here now. Because I've got, I think, placenta previa going on. No, excuse me, abruptio placenta going on. I've seen it. I've seen it from trauma patients. But that's only if the baby is engaged and kind of like has plugged up the vagina. If the baby's not engaged, the blood's going to come right on out the vagina. You can also have uterine rupture where the uterus pops, okay? And of course, as with any ruptured viscera, it's going to be very, very painful for the mother. Their abdomen's going to be killing them. They're going to have pain to palpation, as with any ruptured organ, all right? I'll talk about meconium in just a minute. You're going to have difficulty feeling a nice, smooth uterus, nice, round, smooth uterus. You'll have difficulty because it's not smooth anymore. It's ruptured. If you're really good, you might be able to feel fetal parts outside the uterus, but you got to be really good to do it. I used to work OB for a little while, and I was even not good even when I worked it about Leopold's maneuver and feeling OB fetal parts. I was not even good then. So it's really hard, I think, to feel the fetal parts outside the uterus. Maybe, but it'd have to be a pretty daggone big rupture for me. So I think that's hard. I could feel maybe what I thought wasn't a real smooth uterus, but it's hard. It's really hard to feel. I think it's hard to feel. Now, but this is something that I saw a fair amount of time, not many, but if you see it 5 times in your career, that's a fair amount of times. Meconium in the urine of the mother. When I go to put the Foley in the pregnant woman, and I would get meconium in the mother, again, butt pucker. Like, ooh, no, get me a doc. Get me an OB doc. Okay, so you wonder, how in the world does meconium get into the urine of the mother? Well, this is exactly what it means. It means a ruptured uterus. So in the wreck, typically it's a car accident. Could be a fall, but it's usually a car accident. The uterus ruptures. When the uterus ruptures, the baby gets in distress. I mean, it's a pretty daggone wreck to cause this. And so the baby gets a big whopper, big smack. And so the baby gets distressed. And typically the amniotic sac will break along with, if it's big enough to rupture the uterus, it's big enough to rupture the amniotic sac. So the amniotic sac ruptures, the baby is in distress, so the baby passes meconium. At the same time, if it's big enough to break the uterus, break the amniotic sac, it will probably pop the mother's bladder. Very common to pop the bladder in pregnant women. So when the baby's passes meconium, it comes out of the hole in the uterus. Very common. You know, just think about it. There's water in there. And so it squirts it out of that hole. And the meconium comes out, and meconium is heavy. So meconium by gravity goes down and it goes into that ruptured bladder. So that when you go up with your Foley, meconium is going to come out your Foley. And you will see that dark looking color come into what urine you do get in there. So meconium in the urine of the mother is classic for a uterine rupture. How else can it get there? There had to be a hole in the uterus in order for meconium to get out of the uterus to get into the bladder of the mother. And as I said, I've probably seen it 4 times, maybe 5 in my career, in my 20-some years in the emergency department. But it's a classic sign. And then, of course, just fetal distress to the baby. The baby got as big a hit as the mother took, usually in the 3rd trimester. And so again, it's going to be a change, either hyper movement or hypo movement, tachycardia or bradycardia on the baby and their fetal heart tones, or the mother is dead. And of course, you know, if the mother's dead, the baby's not getting their flow of oxygen through their placenta. And so maternal CPR is going to result in fetal distress. So that would be a concern. We got to get the baby out of there or the baby will die with the mother.
Janie, can I ask a question?
Sure.
As far as the complications you were just going over. So at what point, I know you said you do everything the same until it gets to, until you get to H. But so as far as once you get to H, you start looking at the pregnancy stuff, then does it go back to circulation being an issue if at that point you see that the mom is bleeding or that she's hemorrhaging?
Yeah, right. It's if the mom is hemorrhaging, we got to save the mother. We always save the mother. We always save the mother. As we're going to talk about in just a minute, but we always save the mother. We're going to talk about that in just a minute, okay? Give me just a second, see if I answer your question.
Okay.
All right, so these are just some of your typical, well, actually, I'm going to do it right now. So ABCs. It's always ABC. So what are some typical ABC issues we see with the pregnant woman? Well, gas exchange. So, they've got this big old gravity uterus, which can affect the blood flow, which can affect their breathing. So you need to you can't sit them up. Remember, you can't sit them up because we've got to clear their backs. We've got to clear their necks. So we need to try to log roll them on their side and then try to keep their back straight. You all tell me you take them off their backboards now. So we've at least got to log roll them and get them on their left side and try to put a wedge under them and keep them as straight as we possibly can and get them on their left side to prevent supine hypotension in these patients. Plus, they probably will breathe better on their side than they will with the big old gravity uterus under them. So position them as soon as possible. This will also help prevent aspiration due to that big old gravity uterus. Get an OG tube down to decompress their stomach because that uterus is pushing on their stomach again. So you're worried about aspiration on these patients. Fluid volume deficit, just like any patient, they're going to get isotonic solutions, 3 to 1. If we go to blood, it's going to be 1-to-1, just like the non-pregnant patient. It's no different. There are 2 family members involved. There is decisional conflict. We always save the mother, always. When you hear, oh, save my baby, let me die, that is television. That is not reality, because if the mother dies, the baby dies. There is no let the mother die and save the baby. The mother has to live in order for the baby to live. So it's not like go on and deliver the baby and let the mother die. That's unrealistic. That is unrealistic. Now, if there was a gunshot wound through and through their head, there's always exceptions to that rule. But when you're talking multiple trauma, the key is to keep the circulatory status of the mother going, which keeps the circulatory status of the baby going. So it's not a matter of go out and say, okay, Dad, we can save the mother or we can save the baby. Which one do you want? That doesn't happen. That does not happen. Because the number 1 cause of fetal death is death of the mother. So you save the mother and then you save the fetus. And I got tickled. And it's an old show now, and students always send it to me, and I have it on a disc, but I can't get it to upload for whatever reason. It's probably a firewall thing. There used to be a show called, I think it was called Boston Med. It was Boston something. And this girl comes in, she's pregnant, big and pregnant. And she's, she's big and pregnant, but she's obviously pregnant. And she's a stab wound to the heart. And the ER doc is working hard on this. And it makes the nurse look like an idiot, by the way. I don't really like that part of it. But this doc is working really, really hard on this woman. And the nurse keeps saying, do you want a fetal monitor on her? And he says, no. And he's working. And the nurse says, do you want a fetal monitor on her? And he says, no. And he's working. And the nurse says, do you want a fetal monitor on her? And he looks at the nurse and he says, do you not understand that if I don't save the mother, I don't save the baby? I don't care about the status of the baby right now. I care about saving the mother. If I save the mother, I save the baby. And I'm sitting there going, that's the whole premise. I don't need to know what the baby's doing. I got to save the mother or the baby's going to die anyway. And I said, if only my students could see that. That's the whole principle of this. If I save the mother, then we'll work on the baby and see how the baby did. But if the mother dies, the baby dies. The key is to save the mother. So that is the key. You got to save the mother. And then we'll see about what happened to the baby. But if you don't, the baby will die. Now, granted, if the mother came in and had gray matter hanging out of her head, or her head's been decapitated or whatever, yeah, let's get the baby out of there. Let's do a quick C-section and get the baby out of there. But our baby's not our first concern. If we can intubate the mother and keep oxygen going, then the baby's going to get oxygen. The baby's fine. Save the mother. There's exceptions, but save the mother. Okay. All right. So another specific type of trauma is chest trauma. Now, of the traumas in the United States, 75% of all traumas will involve the chest. So chest trauma is a very, very common type of trauma. It can also be penetrating. So, of course, something's going inside the chest. It can be blunt, where it's just diffuse trauma, but it didn't penetrate into the chest. All chest trauma is serious, and it's not just your lungs. Just like when we talked about thoracotomies, it can be your lungs, it can be your heart, it can be your aorta, pardon me, it can be your mediastinum, it could be anything, it could be your heart. Chest trauma involves more than just your lungs, okay? So any kind of chest trauma is considered very, very serious. So let's talk about different kinds of chest trauma. The most common when we talk about chest trauma, and we're kind of going from maybe the least serious to the most serious, I guess. Well, just common. The most common by far is a fractured rib. Now, a fractured rib is simply a crack in a rib. It is the most common type of chest trauma. And if it's just a fractured rib, it's just a crack. That's all it is. It's just a crack. If it gets displaced backwards, then you're going to have other complications. But the fracture itself doesn't affect any other organs. It simply is a broken bone. But if it gets displaced backwards, it could puncture something behind the rib, but it doesn't have to puncture it. So it could cause a puncture in the lung. It could puncture the liver, the spleen, the heart. It could cause worse problems. The spinal cord. Breaking of the first rib can cause a spinal cord fracture. But a fracture itself does not mean you punctured anything at all. It just means you cracked your rib. That's all it means. So the number one clinical manifestation, the number one symptom is pain. A broken bone. You have pain. The problem with fracturing a rib is you can't cast it, you can't immobilize it, and you can't make your chest not move. So, pain with movement with a broken bone hurts. So every time you take a breath, your chest hurts. So you try not to breathe very well. You try not to move. You try not to take a deep breath. You try not to cough. You try not to do anything. So it just hurts. The problem with that, well, we'll get to that in just a minute, but it hurts. So pain is the number one clinical manifestation. They'll diagnose it with a chest x-ray. They'll take a chest x-ray and they'll look at the chest x-ray and they will see a little crack in your rib. I took a course on how to read a chest x-ray. And when you take a course on chest x-ray, you're amazed at what you actually look at. But the first thing they have you do when you read a chest x-ray is for us immature people, though, I mean, I'm sure radiologists, it's kind of like us with EKGs, we can look at EKGs and tell you exactly what it is without really going PQRST, but we have you all do that. So the first thing they had us do is take our finger and we had to run our finger across every single rib, looking for, was there any evidence of any crack in any of the ribs? Because we wanted to see, were any of the ribs, was there any malformities or anything in any of the ribs? So the first thing wasn't to look at the lungs or to look at the heart or to look at the diaphragm. It was to look at the ribs. It was the first thing we looked at. We had to run our finger across it. I'm sure radiologists can look at it and see the ribs in one glance, but we couldn't. We had to look at every single rib all the way across, just like you all have to do PQRST. So it's diagnosed with a chest x-ray and you simply see a crack in the rib. Physical exam is point tenderness. Point tenderness, as you already have learned, is for a broken bone. So you would rub your finger and when you touch it, they go, oh, right there. Oh, right there. Right there. It hurts when you touch. Point tenderness is for a broken bone. They won't say, well, it kind of hurts all over. It will hurt right where it's broken. That's what point tenderness is. Point tenderness is for a broken bone. So you're going to look at that. So the nursing diagnosis is pain related to movement of the chest. These patients, we do medicate. We don't want them not taking good breaths. We want them to take good breaths because they are at risk for ineffective breathing. If we can't get them to take deep breaths, they will develop atelectasis, which is collapsed alveoli. They will develop pneumonia. They can develop hypoxia and the acute respiratory failure, and they can die. So the key is we want you to move. We want you to walk. We want you to take deep breaths. We want you to keep your lungs clear. It's going to take 6 weeks for this bone, just like every bone, to heal. Therefore, they should be on good pain medication to start out with. It'll take narcotics at first, and then slowly move off of narcotics. So Medicaid is prescribed, and get them to take good deep breaths. Right? No wrapping. We're going to teach you to hold a pillow. We're going to teach you how to hold yourself when you cough. We're going to teach you how to splint, but no wrapping. When I was a new nurse, we were taught to wrap. We would take that 2-inch cloth tape, and we would wrap it like almost a cast all the way. We'd shave their hair off so it didn't pull when you came off. And we would wrap it all the way around their chest, almost like a cast. And we found we gave them pneumonia because it was so tight they couldn't breathe. We don't do that anymore. We found evidence-based research showed that we were causing more problems than we were helping. So there's no wrapping anymore. We don't wrap tape around them or anything like that, or anything tight. We simply teach them, give them pain medicine, and teach them how to hold a pillow and how to hold themselves and splint themselves so they will take good deep breaths. Use an incentive spirometer, and have them actually set up a plan on when to cough, when to take deep breaths, and when to use their incentive spirometer. So a fractured rib is the most common, and it is simply they tend to take shallow breaths, and that will cause respiratory acidosis. They'll retain their CO2 unless they take good deep breaths. Okay. All right, so it's 9:54. I'm going to see y'all back here at 10:04, and we're going to continue with more chest trauma. All right, I'll see y'all at 10:54.
Hey, Janie.
Yes, ma'am.
Quick question for you. So if the fractured rib does lacerate the spleen or the liver, does that then become an abdominal trauma and you don't give them pain medication?
Yeah, they're going to have to go get that repaired. But except we have a diagnosis. Remember, it's no pain medicine until a diagnosis is made. So the minute they see it's a pneumo, or the minute they see it's a lacerated liver and they've got this free blood on ultrasound, then we have a diagnosis. Therefore, they can have pain medicine. No pain
so there's no
medicine until a diagnosis is made.
For all traumas, not just abdominal.
No, just abdominal. Well, I mean, obstetrical would until we make sure what obstetrical is. I mean, gynecological is still abdominal too. I mean, I think about things like, doesn't have to be trauma. You come in and they don't know if you have an ovarian cyst that's ruptured. They're not going to give you pain medicine for that either. I mean, that's not trauma, but same principle.
Okay, so just kind of use your best judgment in terms of when it's outside of maybe abdominal.
Right. But they're not, once they know what it is and how they're going to treat it, then you can have pain medicine. So if it displaced backwards and lacerated your liver, then they know what it is and they know how they're going to treat it. So give you pain medicine. It's when they're using your pain as a diagnostic tool. Then you do not give them pain medicine.
Okay, thank you very much.
No problem. Any other questions? Nope. Okay. I'm here if you need me. I'm going to dig out some teaching aids.
Janie.
Yes.
It's Helen. I found I just typed in Boston Med pregnant. I found the exact scene.
Oh yeah, with that she's 17 years old with a stab wound to the heart or something like that.
She's shot in the heart. Yeah.
Oh, shot. Okay, I knew you said something.
I'm gonna send it to you. Literally word for word what you said. we are going to save the mother, looking at the nurse like she's an idiot.
It doesn't make the nurse in very good light. I agree.
I'm sending it to you.
My aunt died yesterday. Who's sad? $45 watts. It's 45 watts. Volts, 33.3A. Volts. I can't tell what that is. I get thing to do. 19.5 volt, 2.31. 19.5 volt. Okay, it's 10:04. Get that out of the way. So the next thing is a specific type of rib fracture, and that is a flail chest. Now, different books describe a flail chest in different ways, but pretty much what they're trying to say to you is that you have 2 or more fractures in 2 or more adjacent ribs. So I'm going to draw a picture right here for you. Let me get my little pen out here. So let's see if I can do it. That's your sternum. Okay. So this is one rib. This is another rib. And this is a third rib. It's pretty low on the sternum, but you all know what I'm talking about. Okay, so those are 3 ribs right there. So if you crack a rib, this right here is a rib fracture. You made a crack in a rib. That is simply a rib fracture. Okay. If you crack this rib in 2 different places, that is still, you have 2 rib fractures. Okay. If you crack this one at the same time, you have 3 rib fractures. Well, you also crack this one. You have 4 rib fractures. Well, you also cracked this one over here. Now, you have 2 or more fractures in 2 or more adjacent ribs. So I got 2 fractures in this rib. I got 2 that's supposed to be an arrow. It just didn't look like an arrow. That's an arrow and that's an arrow. You got 2 fractures in this rib and you got 2 fractures in this rib. So, and I'm going to change my color. Maybe that will help you to see this. I'll make it blue. So this right here now is not attached to anything. Now I have a floating segment. This is a flail chest. It could have been 3, 5, 8. It didn't matter. As long as you have at least 2 fractures in 2 side-by-side ribs. Okay, so this rib down here in the third one, you can't see me. It's not a pointer, so you can't see me. The one that's down in this one here didn't make any difference because it's not causing a problem. If there had been another one here, then my segment would have been a larger segment that was free floating. Okay, so it's 2 or more fractures Like this one could have had 3 fractures in it. 2 or more fractures in 2 or more adjacent ribs. The bigger adjacent ribs that are involved, the bigger the floating segment, okay? Now, this results in, and let me change myself back to my pointer, because if I don't have a pointer, I can't point. This results in what's called paradoxical chest movement. Now, paradoxical chest, a paradox is opposite what you expect. So what you expect from me is when I take a breath in, that my chest expands out. And when I exhale, my chest goes in. That is what you expect from me. When I have a flailed chest, that segment that's free floating is paradoxical. It does opposite what you expect. So when I take a breath, this is my flailed, where my hand is where my flailed chest is. So I take a breath, my chest expands, but this segment sucks in. So I have this area that sucks in when I take a breath. And then when I exhale and my chest goes in, this area pops out. Sucks in, pops out. Sucks in, pops out. So the paradoxical ones go opposite what your normal chest is doing. What that means is that the negative pressure that's popping open your alveoli is not working under the paradoxical chest segment. There's a change in the pressure gradients. So that segment, there's ineffective gas exchange going on under your flail chest. So obviously, the bigger the flail chest, the more hypoxia you have, the increased acute respiratory failure you have, because those alveoli are collapsed because of they're not popping open with the negative pressure. Plus, they got more broken ribs, so they don't want to breathe. They're either breathing more shallow, and they're not coughing because it hurts. They've got multiple fractures, at least 4. 2 in one rib, 2 in another. So they don't want to take a deep breath at all. So this person isn't just maybe have poor gas exchange because it hurts to cough and they're breathing really shallow, but this person also has a segment that's paradoxical and gas exchange is not happening underneath the segment.
So Janie, can I ask a question?
Sure.
So when a patient is breathing in, the rest of their ribs are going out, but the segment that is free floating is going in, and that causes the lungs to not be able to expand to their max capacity, which is what's causing them to be hypoxic?
Well, yeah, it's affecting the negative pressure isn't happening under that segment. So negative pressure is when you're sucking in air, and so it's popping open your alveoli. Well, theirs is going in and negative pressure isn't there. So all the alveoli under that segment is not popping open. So they're not exchanging oxygen.
And it's just under that segment, or because they're not really wanting to breathe because of all the fractures and the pain, it's probably all over?
Under that segment are the alveoli that are not popping open. The rest, maybe they aren't taking as deep a breath because of pain, but the alveoli are open. They're just maybe not as open as much as they should be. But these are not open at all.
Okay.
So if you remember the 4 things, not taking a deep breath is hypoventilating. Not open at all is the increased intrapulmonary shunting. Not that you have to know that. But remember, one of them was just sort of collapsed a little bit and one of them was shut closed. If you remember that during acute respiratory failure. So it's really 2 different things, but they both result in hypoxia. Okay, so what do we see in our patient? what are the clinical manifestations? What do you see in your patient? Well, you see an unequal chest. This is the one that you truly look down and say, wow, I don't see equal rise and fall. I see a paradoxical. I see a section sucking in and going out opposite than the rest of their chest. You actually see an unequal chest movement. They're just not rising and falling together. It's paradoxical. They are in respiratory distress and they are hypoxic. Their pulse ox is down. Their PO2s are down. They are hypoxic and they are working hard to breathe. So they are tachypnic. They are very tachypnic, okay? And they are restless because they have RAT, restlessness, anxiety, tachycardia, and tachypnic. And because they are hypoxic, they are cyanotic. These people are in respiratory distress because they have a whole area of their lung where gas exchange is not taking place. On X-ray, we will see 2 or more fractures in 2 or more adjacent lungs, 2 or more adjacent ribs. I heard myself, 2 or more adjacent ribs. I don't know how many lungs you have. Okay. 2 or more adjacent ribs. So what is it? Ineffective breathing. It's not an airway problem. It's a breathing problem. Okay. Related to changes in their thoracic pressure. They are hypoxic. They need oxygen. They are hypoxic. So we put oxygen on them. We give them some pain medicine because they're not wanting to, it's fractured ribs and it hurts. We want them to take as much breath as they can. We want to try to keep this from popping out, or try to keep this negative pressure as much as we can. So we typically put something over it, like a sandbag. Well, how many of you all have sandbags? Well, the ER probably has some sandbags. Medic will have some sandbags, because they usually use them for put beside the head. But if you didn't have a sandbag, you could put like an IV bag over it. That's something that's kind of heavy and would sit there really good. Something that when it pops out, doesn't let it pop out as much as normal. So that might help it to maybe not change its pressure gradient quite as much. But what we will typically do is, because they're so hypoxic and in such distress, is we will go on electively paralyze them. And we will go on and intubate them because they become very, very hypoxic. Electively intubate them, take them to the operating room, and they will simply repair this. And the way they will repair it is they will go in there and they will wire their ribs. They will go in there and they will just simply come in and they will just put some wire. And this will stabilize those ribs. And now the ribs are moving back and forth just like they're supposed to. They will get extubated immediately, cold turkey, and they're breathing on their own just like they're supposed to. But before that happens, they are in pretty severe distress. But it can be fixed fairly easy. But I have to say, every flail chest I see gets intubated. It's pretty standard. We don't let them just keep going downhill, downhill, downhill where they might arrest. When it could be, we can support their ventilations and get them onto the operating room. So 2 or more.
Hey, Janie,
Yeah.
they just keep the wired ribs in there after, just keep the wire in.
And they're MRI compatible. It's MRI compatible wire. So if they have to have an MRI later, it's not going to come push it out through their skin or anything like that. Okay, so risk for ineffective airway clearance. Again, that's probably because they weren't taking deep breaths and they got a lot of mucus and stuff in there. So we would like for them to take deep breaths before they go to surgery. So that would be to medicate them and try to get them to take deep breaths. It's hard. Once they get intubated, keep them suctioned until they go to the operating room, and IV fluids to keep them hydrated. So that would help with airway clearance the most. But the key is, let's get them to the operating room. This is not somebody we run down the hall with. I don't mean that, but this is not somebody that sits all day waiting to go to the operating room either. They get placed in one of the trauma rooms that they keep open to get traumas into. But this isn't somebody that we have to rush right this minute, but they go as fast as possible, as soon as they can get a room open for them. Okay. So the next one, the next condition is a pneumothorax, a hemothorax, or a pneumothorax. Now, a pneumothorax is air between the lung and the chest wall. A hemothorax is blood between the lung and the chest wall. And a hemopneumothorax is air and blood between the lung and the chest wall. Now, with that said, they all result in this pocket of either air, blood, or both builds up and results in collapsing the lung down. It displaces the lung backwards because this pocket builds up and makes the lung get squashed. With that said, I will call all of them a pneumothorax from now on because it's hard for me to say pneumothorax. I just keep saying the same thing over and over and over. So even though I call it a pneumothorax, I am talking about something that collapses the lungs, a collapsed lung. It could be air, it could be blood, it could be both. So I'm going to take the privilege of calling it a pneumothorax with the understanding that it could be blood or air or both. Okay, I reserve the right to say that. Okay, this picture here, I know it's not the best picture in the world, but it does show, by the way, this is a dead person, okay? Because you can actually see, where's my pointer? Come up. Oh, wait, I think I'm still pinned. Just a minute, I got to take it back to a pointer or you all can't see it. You can see the ribs have been cut off here, okay? But the reason I have this picture up here is I want you to see that the lungs are in two completely separate cavities. Affecting one lung does not affect the other lung. So I can do something to this lung right here, and it is not affecting this lung. I can deflate this balloon here, and it does not deflate this balloon right here. Okay, so just because you open up your chest on one side does not mean that you open up the chest on the other side. Just because you break this rib here does not mean that you have damaged this lung right here. Now, this is your pleural lining here, and we're looking on the outside. Okay, so the pneumothorax would be on the inside between the alveoli and this tough texture right here. All right, so if blood collected, let's say there was a hole or air collected, there was a hole in your alveoli, then it can't get out. It can't get outside here. So you're going to get a pocket of blood or a pocket of air caught right in this corner because it's not going to get out of this fibrous looking stuff right here. So a pocket of blood or a pocket of air is going to collect right here, and it's going to collapse that one cell thick alveoli that are in those little grape clusters are just going to collapse right on down as air or blood just keeps collecting and getting bigger and bigger and bigger and bigger. It's just going to collapse down those little clusters of grapes in there of alveoli, little one cell thick alveoli are just going to get squashed by big old pockets of fluid or air. And that's a pneumothorax or a hemothorax. Okay, so you can see this is your heart, by the way. This is very, very fibrous, and the diaphragm's not there. The diaphragm would come up under your lung right in here. It's not there. So, but I just wanted you to see how fibrous that looks, how thick your pleural lining is. It's very, very thick. And so that air gets, if the alveoli gets a hole in it, blood or air gets trapped in there and it just starts collapsing it. I also want you to look, there is no stone wall in here. Oh shoot, quit that. There's no stone wall in here. So this is all open sort of in here. So there's nothing that separates the two big time. It's very loose in there. because we're going to talk about it coming and sort of invading onto the other side. So you can see why it can move over to the other side very easily, or how it can squish the heart very easily, because there's nothing in there blocking anything. We talk about the mediastinum, but there's no wall in the mediastinum. It's just sort of the middle. There's nothing really there. So I just kind of wanted you to see what the picture looked like. Okay, so that was the next slide, wasn't it? Yeah, okay. A pneumothorax is simply a hole in the chest wall that, well, there's an open and a closed. There's an open and a closed. So an open pneumothorax would be a hole in this. Okay? In this fibrous stuff. So like if a gunshot wound or a stab wound or a piece of wire or surgical scalpel, something like that went and caused an opening in this right here. So when you breathe by sucking pressure. You breathe through your nose, you breathe through your mouth, and you would breathe through this hole. And when you breathe through this hole and air rushes in, it's going to collapse the alveoli underneath it. And when you collapse that, gas exchange will not take place. This is called a pneumothorax. So an open pneumothorax is because something came in through the opening in the chest wall and collapsed the alveoli underneath it. A closed pneumothorax, let me go back to my picture again, is because something hit your chest wall and maybe due to pressure pop that alveoli inside, and now when you take a breath, doesn't have to be hit your wall, but something made the alveoli pop. So now I take a breath through my nose and mouth, I inhale, and most of my air comes back out my nose and my mouth, but a little bit went out that little hole and got trapped in between the chest wall and the alveoli. Took another breath, little bit, most of it came out. Took another one. And eventually I have a little pocket of air. What besides trauma, like a big 2x4 across my chest, or a steering wheel, or just falling off of a ladder and hitting my chest? But what else could it be? Well, it could be COPD, where you get real stiff lungs, or it could be cystic fibrosis where you get, or pulmonary fibrosis where your lungs get really stiff and they just sort of pop because they're really stiff. It could be cancer that just sort of ate my alveoli away. Could be anything that's like pathological in my lungs could cause it also. Those are, those are called spontaneous pneumothorax that weren't traumatic. So it could be either open or it can be closed. If it came from the inside, it was a closed pneumothorax. If it came because you went through the chest wall, it's an open pneumothorax. So this shows an open pneumothorax, this picture does. And so there was a hole in the chest wall and air is coming in and air's collecting and it's collapsing the lung. It's collapsing the alveoli. And when it collapses, then gas exchange doesn't take place. Now note the other lung is still up because the two are not connected. And so the other lung is still up. But this patient has a severe dyspnea because they are hypoxic. One of their lungs is not working. They're in severe respiratory distress. Now, as air is sucking in through here, the tissue is sort of raggedy. Okay, and so air is trying to go through there. And as air goes through there, it makes a sound. It goes. Open pneumothorax are called sucking chest wounds. And it's the sound it makes. And it's simply the tissue, sort of air going past this, blowing in and out through this raggedy tissue. And so you may hear they have a sucking chest wound, and that's an open pneumothorax. Okay? So clinical manifestations of an open pneumothorax is sucking or gurgling on inspiration and expiration too. They are in severe respiratory distress and they will have an asymmetrical chest. Now it's not like a flail chest with the bulging, but you might have one side sort of rise more than the other side, the side that's not deflated. A closed one doesn't have a sucking chest wound because you don't have an opening, okay? But they are short of breath. They have pleuritic chest pain, very common. They are tachypnic because they are hypoxic, RAT, restlessness, anxiety, tachycardia, and tachypnea. They are cyanotic because they are hypoxic. You will have decreased breath sounds. You have decreased breath sounds with both of them, but you have a hard time hearing them on open because of the sucking chest wound. And if it's been there a while, the air is trying to get out. It moves from an area of higher concentration to an area of lower concentration. So they may have that subcutaneous air that Rice Krispies under the skin because it's trying to move out to here. This is low concentration. That's high concentration. So you might get subcutaneous air.
Janie,
Yeah.
I actually had a spontaneous closed pneumothorax as a kid from an asthma attack, and I had the Rice Krispies under the neck. And
Oh, did you really?
Mm-hmm.
Oh, that's not good.
Yeah, it was not good.
Did they put a chest tube in you?
I did not have to have a chest tube, but we were actually at the doctor, and they were like, go straight to the ED. And a nurse met me like in the ED, took me straight to a room, and then things got a little crazy and
Oh, that is
congested.
good.
But yeah.
And your air was in your neck?
Mm-hmm. Yeah. So I had the Rice Krispies, stiff neck. It was pretty
that's-
bad. By
When
the
I
time
was
I
a
got,
kid with Rice Krispies in their neck, the most common thing that I think is they had something in their mouth and they poked the back of their throat, like a pencil in their mouth, and they poked their throat. I've seen that several times.
but yeah, it was
Well,
from
that's
an
really-
asthma attack that
that's
just
really
didn't
bad.
resolve.
Really interesting. That is interesting. That's not good. That is not good. Hemothorax, of course, is bleeding into the pleural space. Your lungs are very, very vascular. And so you typically can have a lot of bleeding in there. It can be both penetrating and blunt. You can get blood. The blood is just like the air. It simply fills into the space and collapses the alveoli, whether it's air or whether it's blunt. Excuse me, whether it's air or whether it's blood. It still results in the collapsing of the alveoli, and your patient becomes hypoxic and has basically the exact same symptoms. Now, when you have either a pneumothorax, a hemothorax, or a pneumohemothorax, the treatment is we must re-expand the lung. We've got to get the lung back up, all right? And so a pneumothorax is air in the pleural cavity resulting in their lung collapse. And you can see these are all the signs. We've already talked about them. You can see they've got one down. And so what was the causes? A ruptured bleb. A bleb is an alveoli. And it could be from trauma. It could be from infection. They said a thoracentesis. We've already talked about thoracentesis, where they go in and take a percutaneous through the skin thoracentesis. Diagnosed with chest x-ray, we would see a down lung on a chest x-ray. We would see ABGs, they would be hypoxic. We would have decreased breath sounds when we listen to breath sounds. I hate that they're listening in the front, but you would have decreased breath sounds. You would listen in the back. And the treatment is going to be a chest tube. And so we're going to cover chest tubes. All right. Now, before we get to chest tubes, we're going to talk about a very special kind of pneumothorax. And this is called a tension pneumothorax. Now, a tension pneumothorax is a medical and surgical emergency. This is an emergency situation. Now, what this is it is a pneumothorax that is pretty much out of control. It is a pneumothorax that keeps building and building and building. It collapses the lung, but it doesn't stop. The balloon keeps getting, even though it collapsed the lung, keeps getting bigger and bigger and bigger and bigger, so big remember I said there is no brick wall, that it actually starts to encroach upon the other lung from the outside. So what happens is, this is your pneumo, okay? It's collapsing this lung right here. Oh, I gotta get my pointer up here. It's collapsing the lung up here. It's almost always with closed, because if it was an open pneumothorax, it would just go out the hole. The pressure wouldn't build, it would shoot out the hole. So it's almost always with closed pneumothorax. So the pressure builds and builds and builds, and it compresses the lung, which we know. But now it doesn't stop. It keeps building and building and building and building. So now it is starting to shift and starts to push on this lung by just squeezing it closed on the outside. It's just pushing the whole closed, that fibrous wall. It's just pushing it all closed. Oops. So it's actually pushing it over, and it's causing a mediastinal shift. So it's actually starting to squeeze both lungs. So they are even in more distress, more hypoxia, more cyanosis. They are worse and worse and worse. Well, as everything is shifting away from the injury, your trachea starts to have tracheal deviation, because it's just pushing it's just squishing everything over, not just one side, but everything starts to get squished. Now, it also squishes your heart. And not only your heart, but the aorta coming out of your heart, as it pushes and pushes and pushes and pushes, it does this to your aorta. So the blood trying to come out of your left ventricle can't come out of your left ventricle. Blood trying to go into your left atrium can't get into your left atrium. Therefore, the blood in your superior vena cava can't get out, and the blood trying to get out of your external carotids can't get into your vena cava. So everything's backing up, and so you get jugular vein distension. So in a trauma patient, jugular vein distension is a sign of a breathing problem. It is a tension pneumothorax. In a trauma patient, it is a sign of a tension pneumothorax. So they have severe dyspnea that's getting worse and worse and worse, severe hypoxia, deviated trachea, JVD, cyanosis, and they're showing signs of cardiogenic shock. They're backing up, backing up, backing up, backing up, and they're getting JVD. So this is showing some JVD that's not bad. If you've never seen JVD, this is JVD right here. Let me show you what a tension pneumothorax JVD looks like. I think even you all would pick up on that one. That's tension pneumothorax JVD right there. And I hope you can see that. That is not normal. That's JVD. That's impressive JVD, by the way. Yes.
So with the closed pneumothorax, is the air able to escape the pleural space? Like, are we concerned that it could potentially shift to mediastinum in that as well?
Potentially shift where? I'm sorry, you broke up.
Oh, for the closed pneumothorax, is the air like in any way able to escape the pleural space, or could it potentially shift to mediastinum as well?
Oh, typically it will stay over on the side that it's on, okay. and we will put a chest tube in and just release it.
Okay, so
but if it's a big enough space, like from a trauma that just ripped a whole lot of alveoli out of there and it's just collecting really, really, really fast, then it can cause a tension pneumothorax, which is life-threatening.
Okay, all right.
which is life-threatening. So we've got this one that we're seeing is pushing, and how do we know it? Because they are in severe distress. Severe. I mean, they are in distress. And so we see this JVD, we see this deviated trachea. So this balloon is getting bigger and bigger and bigger. How do we stop the balloon from getting bigger and bigger and bigger? We pop it. We go in and we do what's called a needle decompression. We take a angiocath, an IV catheter, and we simply stick it in their chest and we pop the balloon. We use the second intercostal space, mid-clavicular line, or the fifth intercostal space, mid-axillary line. Why do we do that? Because there's no blood vessels or anything that's dangerous there. And so you look at it and we go, and it goes, now we have a pneumo, but not a tension pneumo. The heart goes back, the aorta goes back, and now we have simply a pneumo to treat. Okay. So when we look at a pneumo, we're back on just a pneumo now. Okay. Impaired gas exchange because the alveoli is collapsed. Typically, unless, and we're not talking spinal cord now, we're simply talking chest here. We've already cleared their neck. If it's a chest trauma, we can sit them up. We want them to take good deep breaths. We want to try to get as many alveoli working as possible. We want to watch their blood counts. We want to get a good baseline on them. It's impaired gas exchange, so we want to give them oxygen because we've got alveoli collapse. Let's load up as much oxygen as we can. It's a chest trauma, so we should put them on oxygen so that we have good gas exchange. We'll give them pain medicine so they will take good deep breaths. Pain medicine is good. Pain medicine is not a respiratory depressant until it is very, very high. A little bit of morphine never depressed anybody unless you are on death's door, then it might. And we're going to put a chest tube in them. You can also have anxiety because when you can't breathe, you are very, very anxious. So explain what you're doing. You be calm, you be reassuring, and you let them know that you are there. Don't just tell them it's okay because you don't know if it's going to be okay, but let them know what you're doing and that, they got a great team and, we're going to now put this tube in, which is going to relieve some of that pressure in your chest and help you to breathe better. All right. So we're going to try to always tell them what they're doing. So chest tubes. So when you put a chest tube in, the purpose of a chest tube is to re-expand the lungs. That is the purpose. It will pull off that fluid or air and allow the lung to come back down, and it'll form a scab. It'll form fibrous tissue and re-adhere to that pleural lining, to that fibrous looking lining. But you've got to clear the air or the blood out of it, or it can't adhere. Okay. So we've got to pull that down. We've got to remove it, and we've got to allow that negative pressure to be there. Now, all types of chest tube work on what's called a 3-bottle system. I don't know that helps you understand it, but it's a 3-chambered system. When I started, and I worked on a cardiothoracic unit, I've taken care of thousands and thousands and thousands of chest tubes. And we had actually 3 bottles. But then they came up with a chest tube drainage system. So you all will probably never, ever see bottles, but it's actually bottles. Now, a healthcare provider will insert a chest tube. You do not insert a chest tube. So they will take a 35, a 34, a 36 French catheter. Now, it's of the same material. Most of them are of the same material of like an NG tube. So it's fairly stiff. It's not entirely stiff, but it's a fairly stiff catheter. And you will go and you will get a chest tube drainage system. Now, they use what's called an atrium system. It looks like this, okay? And when you get ready to set one up, it's very simple. You get it out of the package, okay? And when you take it out, it will be unsterile, all right? And I mean, in the OR, it's sterile. The package is sterile, but once you take it out, it's not sterile. When you go to the back, there'll be like a little pouch here. And in the pouch, there will be either a syringe, a big 65cc syringe, or there will be a little twisty tie little thing that has saline already in it, and you simply click the top off of it. It's all depending on what brand you're using. Whichever brand it is, at the top, there's a one that has a big old long cord, and there's one that has a little short cord. You take the little short cord and you put that syringe on the short cord or the twisty tie one on the short cord. And if it's a twisty tie one, you put it on there and you just squeeze the contents into the short one. If it's a 65cc syringe, you put it on there and you fill the 65cc one time, and it will flow. Both of those will flow into this middle section right here. Now, I told you it was a 3-bottle system, and I can't remember if this has pictures. Let me see if this has pictures or not. You can probably see that picture better. Oh, it does. Okay. So it's got three, I'm going to have to go into the next after lunch section. There's 3 chambers in this system. Okay. So the first chamber is this white chamber right here. This white chamber is a drainage chamber. It is to collect drainage, just like a Foley bag would be. It simply has the drainage come down the tube and it falls into here. Okay. And you can see it measures 10, 20, 30, 40, 50, 60. It all measures. When it gets filled here, the measurement drops over to here. And when it gets filled here, the measurement drops over to here. It will not fill all the way up. If it fills all the way up to here, the patient will go back to the operating room and be fixed. Okay. So it will not fill to there. The middle chamber, this B here, is what's called the underwater seal. The underwater seal is what keeps the patient from breathing air up through the tube and collapsing their lung again. So when you put water in this short chamber right here, the water comes down here and it fills to this little line right here, and it turns the color blue. There's watercolor, little tablet in there, and the water's right here. And so what happens is, let me just do this first. It's the underwater seal. That's your second chamber right here. The third chamber is this A chamber right here. And this chamber you also have to fill. Okay. And on the top of your system, there's a little plug. This is the hole right here. There's a little plug. And you take sterile water or saline, it doesn't matter. And you will pour your bottle of saline to the amount that the doctor has ordered. And it says right here, 5, and I'll point up here, 5, 10, 15, 20, and that's as high as it goes. Most of the time, as you can see by this little dot across here, most of the time they will order 20 centimeters of water pressure. But if they only want 15, then you would only fill it to 15. If they only want 10, you would only fill it to 10. If they only want 5, they would only fill it to 5. Most of the time, they want 20. If they want 20 and then they say, oh, really, I only want 15. Then on the back of your system, there's a little injection port right here. You simply have to take a sharp needle, can't use a dull needle, stick it in there, aspirate back until your water level would drop to 15. So you can change this. And then if they say, oh, I'm sorry, I really want 20. Well, then take your water and fill this back up to 20. And then put your top back on it so it doesn't evaporate as fast. And it makes it muffled a little bit. All right, so now I filled this up with my 65cc syringe. I poured my water to 20 because I'm pretty sure he's going to order 20. I can change it if he didn't. I get my long tube, and then I stand there. I'm ready. That's all I have to do. It's all I have to do is get my system ready. Oh, and it'll come out like this, okay? And there's 3 things that you can do. It has a handle, so it can be carried. Now mine is broken. I will let you know. Oh, it really is broken now. It has 2 little hooks that it can hang like a Foley bag on the foot of the bed. And they just come off the top here. Mine are broken, but it will. So you can hang it off the bed. Or at the bottom, there's a little swivel. So you can just sit it on the floor. Okay, so you can sit on the floor, you can hang it on the bed, or if the patient wants to go for a walk, they can carry it. All right, so I've got it sitting on the floor now, and now I'm ready. So the doc, I'm gonna have it put it in real quick, and then y'all have your break. So the doc is gonna take a chest tube tray. It's just a setup tray. It's just like a sterile tray. They're going to numb it's done at the bedside. They do not go to the operating room. They're going to numb the skin. They're going to make a slit, maybe an inch, 1.5 slit in either the 2nd intercostal space or the 5th intercostal space. Why? Because there's nothing there that you're going to damage. There's no important vessels there or the heart or anything else there. And they're going to take a scalpel and they're going to cut the skin, and so it's numb. Then they'll take a hemostat and they'll poke a hemostat in there and they'll push and push. Well, they actually have it hooked onto the chest tube, and they'll push and push the chest tube. They'll push and 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 push until they pop it through that fibrous tissue. Once they push it through the fibrous tissue and they're in that pocket, even if the pocket's at the bottom, it'll come up to the tube, okay? Then they'll say, okay, I'm ready. You will pull the top off of this and keep it sterile. This is the only part of sterile you have to worry about. You'll pull the top off and you'll plug that into the bottom of the chest tube. And you did your job almost. Then they'll unhook the hemostat and blood and air will come down the tube and will go down into the drainage chamber of the chest tube. Not very difficult to do. Now, then you will put a dressing on the patient. The dressing is you put Vaseline gauze around the tube because I have a slit that has a round tube in it. And the patient's going to breathe through the chest. So we don't want that. So you put Vaseline gauze around here which is impermeable, so the patient doesn't breathe around their chest tube. Okay, they don't breathe around their chest tube. So we put Vaseline gauze around it. And then we take those sponges that you use around the trach that has a slit in it, open up about 10 of them, 15 of them, whatever. Put about 5 of them going this way, 5 of them going that way, maybe 8 and 8, whatever you want to do. So you have a nice bulky dressing around the tube. And then you take that elastoplast, that stretchy kind of orangey, light mauve-y looking tape, a little bit darker maybe than my shirt. And you stretch it, and you put part of it here, part on the bottom, part on the top. And then I usually take one piece and slit it down the middle and slide it around the tube and put one in the middle. So I have a nice occlusive dressing that they're not going to breathe around. And I'm done as far as putting the chest tube in. Now I'm going to assess my patient when we come back from lunch. Have good lunch. I'll see you all back here at noon. Okay? I'll answer questions if anybody wants to. I'm sorry, I kept you 2 minutes over. Bye.
I had a quick question.
Okay, yes.
When you were explaining the different parts of the disposable or the system, you were saying one was the drainage, the second one was the underwater seal, and the third was, I was confused about what the third one did that you filled with the saline.
I'm gonna talk about it after lunch. The third one is the suction chamber.
Okay, okay.
And that's how much suction does the doctor want put to this?
Okay, okay.
Does he want 20, it could be of her, 20 centimeters, 15 centimeters, 10 centimeters, or 5 centimeters of water pressure?
Okay.
So it's drainage, underwater seal, and suction. Those are the
Okay.
3 chambers.
Okay.
Anybody else? All right, have a good lunch. I'll talk to you after lunch. I'll come back and sit here for a little bit, so. My grandchildren are so funny.
Hey, Janie. Can you hear me? I can't hear you.
I couldn't find my Zoom buttons. But yes, can you hear me now?
Yes, I can hear you.
Okay, all right, yes. What can I do for you? Oh,
I
wait a
was
minute.
gonna
Let me turn the, should I turn the recording? You'll remind me to turn the recording back on after break. Recording, pause.